All right. Thank you, everyone, for joining. Tonight, we are having a discussion on institutional racism in healthcare. Today, I am joined by Brandon Johnson and Dr. Alicia Sherrill. So, uh, Dr. Sherrill, could you just give us a little bit of background about yourself?
Sure. Hi, good evening. I am a public health analyst with the federal government, and I manage grants for children's hospitals. And I just recently completed my doctoral work looking at exploring maternal stressors and how it affects racial disparities between Black and white women in the state of Maryland as it relates to adverse birth outcomes, namely preterm birth and low birth weight. Thanks for having me.
Congratulations on that. That's a big deal. And I know that we're eager to hear more about your work,
Sure.
especially as it relates to this topic. Brandon, can you tell us a little bit about yourself?
Absolutely. First of all, I'm excited to be here. I'm Brandon Johnson. I am a suicide prevention expert and have worked in the field for about 7 years. And so primarily right now, my focus is on suicide prevention within the African American population, especially young boys, as well as suicide prevention within faith communities.
Great, thank you. All right, so how would you define institutional racism?
So I would define institutional racism as racism that is really particularly pertaining to policies, procedures, and distribution of resources. So institutional racism really differs from other forms of racism because it is woven into the fabric of an institution, the way policies are structured, and it's designed in a way to take resources, particularly from people of color, or block them from certain resources and have it be distributed to white communities, to white people disproportionately. So we've seen examples of this really throughout history in different sectors. I know tonight we're talking particularly about healthcare and in mental health, but it really crosses a number of institutions and things that have been enacted by law, some state, some federal, that have really impacted people of color, particularly African Americans and American Indian and Alaska Natives.
Sure, I'd agree. I would say it's embedded into the customs and laws that keep minority populations from having the same access to adequate housing, adequate health care, different resources, even information. And we know that historical events have caused these differences in socioeconomic status, and institutionalized racism actually helps to perpetuate those associations between race and socioeconomic status.
Thank you. I think that the definitions and examples that you provided are really helpful distinctions, because I think a lot of times where people get racism wrong is that they think of racism as interpersonal interactions, which it certainly is and certainly can be, but where we really see the power differential perpetuated is within systems and institutions. So thank you for defining that for us. So, institutional racism, as Brandon mentioned, impacts several sectors. So what are some examples of different sectors that institutional racism shows up in?
Yeah, so I mean, it's so many, unfortunately. Tonight, we're really focusing on healthcare and behavioral healthcare. Historically, the field even itself of mental health has really has seen and experienced a lot of institutional racism. I mean, even if you go back to, I mean, some of the founders and some of the pillars of mental health really focused on creating theories and other procedures and therapeutic workforce and frames really around kind of some racist beliefs. And so if we look at, for example, Dr. Samuel Cartwright was he was a really prominent Louisiana physician, and he developed a theory which basically said that it was a mental disorder particular to slaves if they tried to run away. So the fact that they were, mistreated, taken from their homeland, weren't given adequate food and things like that, the fact that they would want to run away from that was a diagnosable mental health condition. And we're talking about in like around like the 1851, somewhere around there. And so like we look at these kind of things and how they have really become a part of how we move theories forward in mental health. There was even a theory around slaves being lazy. If we go more current and look into around like the 1960s, like there were theories that said that physical violence and a reaction to oppression and poverty for African Americans was a part of brain dysfunction. So like we're looking at these things and watching how they evolve, and people feel like these things are so distant, and they're not. And so we've seen them also within redlining and the practice of redlining, which is a financial way that institutional racism really played into society. And really what this was not giving loans to African Americans and people of color who were qualified and who had the credit to make sure that they weren't able to purchase property, land, and to get loans to start businesses, particularly in certain places. And so redlining was actually literally drawing red lines on a map to say, this is where we won't, give loans. These are the people that are high risk, and we won't give them loans. And so this has created a huge financial divide, in our culture as well. So we can look at housing, we can look at mental health, and even in the way psychiatric hospitals were built and where they were built, really plays into this as well. They were specific hospitals where African Americans and people of color, couldn't get services. And when you are able to build things out like redlining and decide where people live, you can also decide their access to resources, places where resources are put. And so methodically, we've seen throughout history that if we look at every structure from housing to finances to healthcare to access to public transportation is another one. If you watch how these things play out, it really impacts access to care. So there are a number of different arenas where we see those.
Yes, I'd agree that I would have to say that institutional racism affects all social determinants of health, which include the conditions in which people live, learn, work, play, and worship. I would say that we would have to understand that the legacy of racism in the medical profession goes all the way back to the days of enslavement, when women just, childbirth in and of itself among Black women was the cornerstone foundation for which slavery could exist and be perpetuated. You have to look at different historical events, including the Tuskegee experiments that lasted over 3 decades in Alabama. You can look at forced sterilization among Black women. You can also look at gynecological experiments, et cetera, et cetera, et cetera. I would also say some basic differential access to clean drinking water, to healthy food options. Also, all of these things affect your ability. And, not having financial investments in Black neighborhoods can lead to your not having adequate access to health insurance or adequate healthcare facilities. But you know what, all of that is on the institutional level. But if you want to talk about what racism looks like on a personal or provider level, when you get into healthcare, you're going to have to look at being disrespected by your provider not offering you certain diagnostic treatments, your provider not offering you the same care plans as they do other people. And lately in the news, we've seen a lot about providers dismissing the pain and distress reported by Black women.
You bring up a really good point, in that I recently read an article a couple months ago that was saying because Black Americans were prescribed opioids at a rate that was less than white Americans, that they actually saved tens of thousands of lives.
Mm.
And everyone kind of looked at the article like, are you really saying that racism just saved all of these lives? Because you're right. You know, when Black people go to the doctor, they're more likely to be labeled as drug seeking, or as lying about their pain, or their pain isn't believed. And I read a really interesting article that actually goes back to times of enslavement, of when enslaved people were used for medical experiments because it was theorized or justified that enslaved people did not feel pain in the same way that white people felt pain. Right. And we still see those ideologies perpetuated today.
Sure, absolutely.
So we kind of jumped into this. Do you want to talk more about on an individual level of what that racism looks like in medical encounters?
Yeah, so all of that I described, what that can do is lead to Black people receiving less preventative health care, such as diagnostic screening. So that can delay early detection of diseases. It can cause general mistrust of medical professionals. It can lower your quality interactions with physicians. All of these things can contribute to racial disparities and a myriad of health outcomes, including diabetes management, cancer mortality, and also infant and maternal mortality.
Yeah, it's definitely kind of pops up in different areas too, and we see it, you know, also within mental health. Like there was a study that was released maybe last year that looked at services that were provided to youth in Georgia who were found to be screened to be at risk for suicide. And so what we saw and what the paper saw was that African American youth were more likely sent to community services versus being put on a suicide care pathway. And so, you know, and this isn't like integrative services where, you know, you get put on the pathway, you get the evidence-based treatment, and you also get a community support. This was one or the other. And so we talk about like implicit bias and just how naturally, you know, really, and they looked at other factors that precipitated it, and nothing really accounted for the difference in the services that were offered except for skin color. And so when you really look at that and kind of tease it out, you know, we spend time putting together things that, you know, we try to make evidence-based and to, you know, really that's grounded in research. And so even when presented with the opportunity to help African-American youth in that way, implicit bias may jump in, and a clinician may say, oh, they'll do better with something that has community supports or something like that. And so not getting African-American youth the same level of care as others. So that implicit bias really jumps into play. And it also comes in a lot when I was at Johns Hopkins. Like we had this class where we looked at patient-provider interactions. And one of the big things that we saw was that clinicians are less likely to want to answer questions from a person of color than a white person. So like there's this ability of being an active participant in care. We oftentimes aren't even given the opportunity by our provider to become an active participant in care, and that impacts our patient and health outcomes.
Yeah, and that reminds me of another study that was conducted about just access to care for Black people in terms of calling and trying to get in with private practitioners for mental health care. And if you had a more ethnic sounding name, you were less likely to get a return phone call or be offered an appointment, which is really disheartening, because when we think about all of the things that the Black community faces, certainly mental health care is a need, right? And to overcome the stigma and the nerves of actually reaching out for help, and then to face this implicit bias, not even being afforded the opportunity to receive the care that you need, it's really disheartening.
Absolutely.
So let's talk more about outcomes of institutional racism. So we've kind of covered access to care, but what effects do we actually see because of institutional racism?
So another one, so when we talk about access to care, there's also the ability and desire to have help-seeking behaviors. We've seen throughout, especially through healthcare, just a lack of providers being being in that space and finding a clinician of color, a physician of color. Like these are all things that we really, really haven't been seeing. And so this has been like this since like if you can look back to like the 1920s when Black providers and clinicians made up around like 2% of all providers. And so and during that time, I mean, just one of the places where Black doctors could even practice was at Howard University. Like that was a big staple, and they pushed out a lot of the African American physicians. But many times when you have these things, and it makes it difficult for people to get proper loans and things, and to get housing, that also impacts schooling. So if it impacts schooling, you're not getting that representation of people going into the field because they don't have access. They're already financially behind. It's difficult to get to campuses. They're starting out less resourced, and so African Americans in predominantly white institutions, like during that time from the 1920s and moving up to around the 1970s, had a really difficult time of even graduating from a PWI. And so this is where HBCUs were so important because we weren't making up the population. And so if you have these, practices that really reflect racism and people aren't coming in to be able to counter it, when we engage with this system, there's a reluctance to, want to disclose things or even be a part of the system. So we watch help-seeking behaviors and, stigma kind of build up over this time. And we're still combating that, even in the mental health arena, to get African Americans to feel comfortable at all with the mental health system. So it definitely provides, a lack of desire to even be a part of the system. And so we're still, watching that today. And so those are some of the issues that we're seeing as well. And as we experience trauma, we are experiencing trauma at high levels, but not having the resources or being able to access resources because of the institutional racism that we've seen has made us reluctant to even engage within the system.
And I'll just add to that also we've had a lot of hospital closures that have created sort of a maternal care desert in certain neighborhoods as well. So it's sometimes hard for people to find transportation and rearrange schedules to even make it to necessary appointments.
I think another way this has shown up, especially recently during the pandemic, is in terms of testing capacity and where testing centers are located and being able to access them. I know that there was a lot of traction around, I believe it was a Black nurse that had died and she had been denied a COVID test several times. So I think that we're still seeing this, and obviously, the disparities of Black Americans dying from COVID-19 are staggering,
Right.
and really bringing to light this issue of institutional racism and social determinants of health. One of the other really staggering, sorry, Brendan, were you going to say something?
No, I was just going to jump into like talking about what Alicia had mentioned earlier, like talking about the Tuskegee study. And, we watch really low rates of African American men to engage in any health system and take preventative tests to really find out things beforehand. Like we've seen that throughout history, and there's a lot of mistrust, especially with research. And so we don't get involved in clinical trials. Like we don't get involved in a lot of randomized control trials because of, things like the Tuskegee study. We've seen institutions profit off of Henrietta Lacks and her cells, and, how that really transpired and how that's still being used today. and so we watch those things, and it also creates that mistrust as well. And so if we're not involved in research studies and have a reluctance with clinical trials, when we go to look up and find what's effective and look at evidence-based practice, the people who participate, the demographics aren't us.
Mm-hmm. Yeah, you bring up a really good point, because there are definitely present day drivers of why the Black community has mistrust of medical providers, but this isn't new. This is something that's been going on historically, and there's a real founded reason for why there is such mistrust among the Black community. I think another one of the really staggering statistics that I had learned within the last year is the disparity with Black women dying from childbirth. And Alicia, I know that that's your area of research. So could you tell us a little bit more about your work?
Sure. So I look more at from the infant mortality side. And I was looking at the state of Maryland, looking at maternal stressors experienced during pregnancy and how that relates to low birth weight and preterm birth disparities. What I did find was that Black women tend to experience more emotional, financial, partner-related, and traumatic stressors compared to their white counterparts. But as far as the maternal mortality piece, so we know that socioeconomic factors are usually a major driver for health outcomes, but when you look at socioeconomic factors, when it comes to infant mortality and maternal mortality, we see that there's still high disparities that exist even when you take into account all those other variables. So, if you look at upper middle class Black women, they still have higher infant mortality rates compared to upper middle class white women, but they also Black women who have master's degrees, doctorate degrees, they still have higher infant mortality rates compared to white women who have less than an 8th grade education. And some of the thoughts behind that is that, your financial stability, your so-called upward mobility does not prevent Black women from experiencing discrimination, racism, unfair treatment in healthcare settings that contributes to these adverse birth outcomes, because we understand that experiencing racism can cause psychological distress, which then can lead to different biological reactions after you're, experiencing stress can cause stress hormones such as cortisol and other stress hormones to be released into your bloodstream that can activate premature birth and also prevent oxygen and adequate nutrients from getting to the fetus, which results in fetal growth impairment, which leads to low birth weight.
Wow.
And it's really serious. I heard Dr. Michael Liu speaking before. He was saying, like, if your mother's pregnant with you during your second trimester, and she's stressed out during that second trimester, and that is when your pancreas is developing. So when you become an adult, your pancreas may be smaller than other adults, and that can make you more susceptible to diabetes. So these health outcomes can have really lasting effects into adulthood.
Yeah, I think that's a really good illustration of how trauma can impact and have impacts that are, passed down between generations.
Mm-hmm.
Brandon and I were talking about intergenerational trauma the other day, and
okay.
Brandon, do you want to talk a little bit more about how trauma transcends generations?
Yeah, I can definitely talk about that. So, we've really seen this, and there are many theories that really kind of address this, of how trauma is passed down. I mean, one, just the stress of constantly having your fight or flight system, really activated over time. And there's also a level of, interactions that we, constantly have, and we haven't been given the proper time or space, to heal. Like, even as we deal with what's happening now and talking about what's happening with Ahmaud Arbery, George Floyd, Breonna Taylor, and the rest, we really haven't had a chance to, to deal with this. And we we look at civil rights and things as being so distant, but it's not. And our parents have lived through things. Our grandparents certainly have lived through things, and so naturally, just even in the way that we're brought up and the way that we're raised, is impacted by this. So our grandparents have seen trauma and know to be careful of law enforcement. There are certain times of the day, like many of us were taught, like, coming before the street lights are on, like, things could happen. Just being careful in certain settings, and so in doing that, there is this way of that we try to naturally protect ourselves, and to constantly be in a state of survival is another big piece of that. And so we talk about this a lot. There is a professor, her name is Dr. Joy DeGruy, and I got the chance to meet her, I guess it's been over a year ago. But she was at a conference and she spoke about post-traumatic slave syndrome. And it's a really powerful theory that she developed, which really looks at, how the issues and trauma of slavery have transcended generations. So it's a really powerful way to look at it. And so some of the things that are a part of it that she talks about is, we have this multi-generational trauma, but we also have this continued oppression. So there's we're dealing with this and our grandparents and things who are stressed, and, it passes down to our parents and through generation. But we haven't had that ability to heal. So there's been she talks about the absence of opportunity to heal or to access the benefits available to the rest of society. And so when we talk about, so what she's talking about there is that the continued institutional racism plus the interpersonal racism and the impacts of not being able to, have access to healthcare, have the finances to take care of ourselves. As we put those things together, it creates this opportunity for us to still stay stuck, in the trauma that we've had just since slavery. So we're talking about trauma through 400 years. She also talks about feelings of hopelessness and depression from watching over generation. Things get better in some areas, or the perception of things getting better, but us still being traumatized by what's happening to us currently, and being able to see things that are still happening, that are kind of behind the scenes. So things aren't as overt now, but they're definitely more covert. And there's a part of that too where other people in other spaces, people who aren't people of color, can look at things and say, oh, things have improved so much better. Like, you all don't deal with those things. And so that also, gains feelings of hopelessness and depression, because it's just switched. Like, it's just different. It's presented different. And so because of that and the inability to heal, we also have a greater propensity for anger and violence. And this is violence against ourselves or others. So really, not having time to heal, being told that these things are going away, and this perception of advancement when we know and feel microaggressions at work, we know when we're passed over for promotions, those interactions where we're walking down the street and somebody, moves out of our way, it goes to the other side of the street. Like, so those things as well are a part of what she talks about. And also too, another part of it is kind of like learned helplessness, and also having an aversion for even people of our own cultural group as a part of this, that we have been put in situations and experiences for so long that we have to fight each other for resources. So like, we can't even, kind of band together and go into this because we've been given, such little advances in times for opportunity that we also have to battle each other. So it also can create some animosity within group as opposed to, outside of the group. So that's a really great theory around it, and really gets into some details about, even for men to women and how it looks different. And so these are some of the ways that we see this trauma transcending your generation.
And to that point, Brandon, when you talk about institutional racism, personally mediated racism, some people will also argue to what you're alluding to about internalized racism, where you as the oppressed group accept the negative narratives about you and your group. And that can affect even some of your health behaviors, that you don't maybe take care of yourself as best as you could because of the negative thoughts that you have about yourself and your race.
Absolutely, absolutely, and it's and it definitely shows up too in spaces like that and in other spaces as well. Like we have because of racism and discrimination, like we experience PTSD symptoms more than any other group just because of what we've experienced. And so for many people, they get the opportunity to have law enforcement just kind of be a blanket positive thing in the community. And for us, it's layered. It's really later. And we get into talking about healthcare, and having access to healthcare is a difficult one. And so if any point in time we come across a physician that wasn't listening to us, or wasn't taking what we were saying seriously, which is often the case with Black women in the hospital, like you mentioned, especially during childbirth, then there are negative impacts of that later. So people may not follow up with the doctor, or not, have that trust there. Like those things are sustained, and gets woven into our behaviors. And I think that's the piece of it that we oftentimes will like people will look over or kind of just glance through, but like there is sustained like impact from these things as well. It was I looked at some of the things about redlining, and kind of brushed up on it before this. And so there's like some data that suggests that each individual African American, as a part of who's been exposed to redlining, missed out on about $216,000 within their lifetime. And we look at those things, and we talk about like generational things, and how institutional racism like plays an impact of that. If you look at that across generations, that's a lot of wealth that we aren't able to go to. Those are missed doctor's appointments. Yeah. Those are elective surgeries that we need, for preventative measures that we don't take. And so like those things are cumulative. And then when you have your health deteriorate, like just looking at like the continuum of this, when you have your health deteriorate, and then your children who haven't been able to benefit from that wealth have to become caregivers, there's the stress of that. Like there's the mental health piece, there's the financial piece, and the housing comes into play. So how do you get that person to their appointments? Like it's all just so connected. And I feel like that's the most interesting thing about it, is that people like silo experiences with racism as if like one has nothing to do with the other. But when you map it out, like it's complex.
Right, and when you mentioned about our interactions with the police, Dr. Fleta Jackson did a study in Atlanta at a clinic, and found that Black women who were pregnant with boys, they had an increased fear that their child would be subjected to police brutality. And that's distress. We talked about how distress can lead to low birth weight and preterm births. It contributes to that, likely contributes to that disparity in our communities.
Something that struck me, Brandon, when you were talking was having negative experiences in healthcare, and how that leads to mistrust, and then less engagement with healthcare, not following up on appointments, not trusting the advice that was given to them by the doctors. And from a provider side, oftentimes that is classified in the chart as non-compliance, which then follows the patient through the healthcare system. And this person comes in with the label of the fact that they're a non-compliant patient, but that's completely negating the experiences that they've had in the medical system, the social determinants of health that make it difficult to engage in healthcare. And I think that's just yet another layer of difficulty that's experienced in terms of trying to seek care and actually engage in it and get what you need from it.
Absolutely. And I think historically, we've been marked by that. And if we, talk about how, some of these theories and, the ways things were done, if we look at that, there's not going to be many of us who are going to be compliant with the system that looks at us in certain ways. Like looking at these, policies and procedures, like you said, like that men are, African Americans are better at taking pain, and so we may not be offered the level of pain relief as others, and we get into these spaces where where we're not heard. We may be compliant, but we may be compliant to things that weren't even beneficial to us in the beginning because there is a lack of engagement and conversation, patient provider relationship being built to actually even go down the right path. And so we may be compliant sometimes, but when we hit that road of like, I was trying to tell you X, you told me A, B, and C was the answer. But if you had listened to me in the beginning, we probably could have come up with something better. Then if they go to somebody else and get the same type of interaction, then they may become non-compliant. Like they may feel like, I'm not going down this road again. I'll figure something else out. And trying to find a provider that takes your insurance, that will build that relationship with you, and can help you to be a partner in that. It takes time, and sometimes we don't have, the time, and so people, people of color, Black people, look for other alternatives, and in the meantime, their condition could be deteriorating.
Mm-hmm. Something I learned today was in response to, it was specifically a thread on Black women not being listened to and heard in the medical field, especially if they're requesting testing or medication and having doctors outright refuse to order the test or the medication, is that you can actually ask the doctor then in your chart to document that they're refusing to do what you're asking. And a lot of people have had success with that then, of the doctor coming back and saying, I've reconsidered, and kind of changing their tune. So I thought that was just a helpful tidbit. I didn't know that you could do that, but I certainly think that's a way to help reclaim power.
Right.
Especially, I also just think about how the cycle gets perpetuated. If you have a poor interaction, then you get deemed non-compliant in your chart. The next doctor comes in, reads that you're non-compliant. That's already primed them in their mind of how they're going to treat you as a patient. So it's just kind of like this never-ending cycle that seems really hard to break.
Absolutely.
It is. I think it's a system issue anyway about, payer systems and trying to herd as many patients in as possible for the day. So patients don't really get enough one-on-one interaction that they need. Doctors are overworked, they're stressed, they're talking to you, they're not looking you in your eye and all this kind of stuff. So all of that contributes to these sort of so-called non-compliance issues.
Definitely. So what are some things that could be done to try to address institutional racism in healthcare?
You want to take it, Alicia?
Well, I was going to say, you kind of touched on it about saying something about, can you document in my chart that you're refusing me this treatment? I heard Dr. Joya Prairie, who is president of the National Birth Equity Collaborative, say that what we can do is practice personal autonomy by being self-advocates and when we have our medical appointments. And the way we can do that is the example that you mentioned. And also we can ask questions at our appointments and not just take what the doctor says as the end all be all. We can do that by bringing someone with us to our appointments, and even a paid patient advocate can come with us. You can also shop around for different healthcare providers. So I think that is a great start that you can do within yourself I also think on a community level, we can support various organizations who are already doing this work to advocate for certain policy changes and disparities research, including Black Mamas Matter organization, Black Mamas Matter Alliance, and their website is blackmamasmatter.org. You can donate to them, you can get involved in their initiatives, you can look up your local March of Dimes and donate to their research efforts as well. I just saw a tweet today from the National Black Midwives Alliance, and they're asking people to join with them as an ally. You can join the association. You can pay dues for a Black midwife to join their association. You can help partner with them with different legislations that they're trying to push. So I think we can start with things like that. And it's a couple legislative things that are taking place now as well that we can keep our eye on as far as maternal child health is concerned. There's a Momnibus Act that was presented early March of this year, presented by Senator Kamala Harris in California and two other Congresswomen, Lauren Underwood and Miss Alma. I can't remember, Miss Alma, I forget her last name. So what that is a comprehensive plan to combat the maternal, Black maternal health crisis in this country. Is like 9 different bills. It's doing a number of things like trying to address social determinants of health, like we talked about, to improve data collection and data quality, to diversify perinatal workforces, to have reproductive justice for incarcerated mothers. It's just a myriad of issues that are going to be tackled. And I did also want to share that in the state of Maryland, there were 2 bills that passed last year that deal with the maternal mortality review program. So now they are allowed to have, the local health departments can now have their own maternal mortality review teams. And also now it's also a requirement that for the annual reports on maternal mortality, you have to include a racial disparity segment. So hopefully with those things going on, we can get some better data collection to address the situation and have some formidable solutions. But the Momnibus Act has not been passed in the House or Senate yet, so we still have to see how that comes down the pike.
Yeah, that's awesome. I mean, I would echo what you said, Alicia. Really focusing on some groups that do some advocacy work in this space. I always advocate for the Black Mental Health Alliance in the space of Black mental health, and making sure that providers are well represented. They have programs where they work with up and coming young professionals in this space as well, and having training that's centered on cultural competency and cultural humility as well is really important. Their website is blackmentalhealth.org, and so I would definitely encourage anybody who's interested in that to work with them. As well, I would also take a look at the Congressional Black Caucus. They really spearhead a lot of efforts on the legislative end in a number of arenas, and really do a good job of keeping the community up to date with what's going through legislation and how you can help to push things through, and to really give you an idea of who's on the different committees as well, to kind of push certain laws through. So the Congressional Black Caucus is definitely another avenue in which to do that. And also, I think too, supporting any programs and things, local HBCUs that are really developing professionals that look like us, that represent the African American community, and can get into places of power to help change these decisions. I think a lot of it, really happens in rooms where we're not in, where we're not represented, or where our voices, are really smothered. And so the more we can have representation, the more we can, really advocate for ourselves, and to push and to make sure that there's a voice, multiple voices, not just a voice, but multiple voices in these spaces to make systemic change. Because really, I think there's a lot to be done on the individual level, but until we tackle some of the things happening with decision makers, I think, it's a tough road ahead. So I would definitely think through that. And also in healthcare, I think another space that, typically is a really good space to look into to see some of the work that they're doing is FQHCs, so federally qualified health centers, have developed into really good community partners in specific communities. So I would definitely take a look at them to see how they're combating this. Way more culturally representative in most cases. So I would definitely, and they provide services on a sliding scale. So I would definitely take a look at what they're able to do as well.
I just want to mention one more organization that I forgot. Since you all are based in Baltimore, I presume your viewers will be as well, but there's one in Baltimore that you can look at called Drum Healthy Families Incorporated, and they're doing wonderful work to combat adverse birth outcomes in Baltimore City. So I encourage you to check them out as well.
Thank you. So I know that this is a very broad topic. It's huge. There are whole classes that could be taught on this. So are there any other thoughts that came up for you all in the course of our discussion? Anything else that you wanted to touch on as it relates to institutional racism in the healthcare system and health outcomes for the Black community?
Yeah, so I mean, one thing that I would just say is, really we talk a lot about health disparities, in our work, and we talk about some of the things that are disproportionate, and even in spaces where we talk about like suicide prevention and in mental health. I think if we're really going to make change and look upstream to impact these things, we really have to look at the systemic racism and white supremacy that exists in many of these spaces, and to Alicia's point, that influence the social determinants of health, because without that, we're really doing patchwork. Like, we can't do true prevention until we really dismantle some of these systems that are keeping people and their health really at bay. And so we're not able to see some of the things that we want to see because we're tackling things too far down the line. So if we look further up and look at ways that we can create policies, meaningful policies and changes that can really help to benefit our people, we won't see the changes that we hope to see. And so I think it really starts there. And I think that fields and institutions really look at how we can break some of the societal issues in order for us to really make an impact on health.
Mm-hmm. And I just want to add, when you talk about the racism that's embedded in the system, from a research perspective, more methodological perspective, we do need, I think, better tools to be able to sort of measure effects of racism on various health outcomes, so we can sort of name a thing and attack root causes, like Brandon mentioned.
Yeah, I've seen a big push to stop using race as a risk factor, because it's really not race, it's racism that is the contributing factor. And Brandon, you and I had this conversation probably 2 or 3 years ago, but racism is a public health crisis. I mean, Absolutely. When you look at any public health issue and you really try to get upstream at what is contributing to this, it is racism. So right. It's been nice to see that that's finally publicly being acknowledged. So I hope that this is the start of some meaningful change, systemic change that needs to happen.
It is evident to me more and more that there's really no way around it, because in maternal child health, maternal child health outcomes are influenced by so many things in your environment and your nutrition and your stress. But, a lot of a lot of health disparities are rooted in the social inequities that we've been talking about. And a lot of that is rooted in racism in this country. So we have to address that.
So for people wanting to learn more about institutional racism in healthcare, what are some resources that you recommend?
So APHA definitely has a page that talks about it and talks about the issues of racism in health. So apha.org would be one place to go. And another, just to get people connected to Dr. Joy DeGruy's work on post-traumatic slave syndrome, her website is Joy, Joy, DeGruy, DEGRUY.com. And so she has, she's written books on it. It's really an interesting topic to look at. So I would recommend those.
Yeah, her book's excellent. For those of you who might be more visual, there is about an hour and a half lecture on YouTube that she gives of her work. She's also been doing weekly Facebook Live videos on Wednesdays. She's calling them Wellness Wednesdays, where she dives into a bunch of these issues that we're facing. So they've been really interesting. She's been really generous with her time.
I would add also to look into the work of Dr. Kamara Jones, who was the former president of APHA, the American Public Health Association. She's a professor at Morehouse Medical College. And also I'll mention again that I think a great source is the Black Mamas Matter Alliance, and you can find them at blackmamasmatter.org because they're very entrenched in this work.
One book that was really impactful for me was Medical Apartheid by Harriet Washington, which really delves into the history of experimentation and exploitation of Black people in the US for medical experimentation and also research studies. So that's a good book to purchase and read if you're more interested in learning about this. So, any final closing thoughts?
Racism, discrimination are a public health crisis, honestly, and we're watching this play out, really publicly right now with some of the things that have been happening. And so I think it's important for us to be educated and to know what the impacts are, to look out for them ourselves, and to those of us who are, in positions of power and in positions of influence, to make sure that we point it out every time that we see it and combat it every time that we get a chance, and to pull people in. I think there's a big village of public health practitioners, like yourselves, that are out there wanting to make change with this. And so I think the more we can rally and support each other, the more chance we have to start to tear some of these systems down.
Right, and I would just say, when you're presented with stressors, either you're going to remove the stressor or you're going to find ways to mitigate and tailor your response to that stressor. And so some of these institutional issues, they're really big issues. They have been longstanding for centuries. So it may take time to sort of continue to navigate through those. So I would encourage us all to continue to take care of ourselves, take care of each other, practice self-care as much as we can, meditate, do breathing techniques, and seek mental help as needed.
Yes, taking care of ourselves is an act of resistance.
Yes, ma'am.
Absolutely.
Well, thank you, Brandon. Thank you, Alicia. This has been wonderful. I'm so happy that you were able to join me tonight to talk about this issue and provide some education. So thank you again.
No, thank you for this platform.
Thank you. Absolutely.